Hi, this is Julie Lubinsky. I am the web manager for Christopher and Dana Reed Foundation, ChristopherReed.org, and I'd like to welcome you all to our second web chat with Nurse Linda. I'm so happy she's joining us again this month. I want to tell you just a little about her. She has been doing our Ask a Nurse series on our community, which is ChristopherReed.org/nurse. And she has been posting every Monday topic discussions in which you are able to ask questions back. And she is live in our community every Wednesday evening, and she answers your questions. And you're also more than, we'd love to have you ask more questions in that area as well for her. And since it's become so popular, we've asked her to start doing these web chats with us. And so I'm so happy to have you all on today. And I'm going to hand it over to Linda to get us started on our first topic.
Thank you, Julie. Welcome, everyone. It's nice to be with you again today. And I hope that you're all enjoying some beautiful weather today as we are where I am. So spring is upon us. This month we've talked about a couple of different subjects, and so the floor is open to your questions. I thought maybe I'd start talking just a little bit about wheelchair fitting and seating, because it seems to be a popular topic that people have enjoyed. And so let's just talk a little bit about that to get us started. You know, it is remarkable that the research has shown that when people are viewed in their chairs, or when they ask people about their chairs, that 80% of people are in poorly fitting wheelchairs, which seems kind of a large number to me. That's a lot of people. So I think that oftentimes wheelchair seating is something that is very, very important, but it's overlooked because of the frequency that our bodies change, we get involved in different activities, and so our needs change so frequently. Oftentimes we are given a wheelchair as a device for mobility. It's for getting around. But we also need to recognize that that chair is important, because that's really where we're doing our living. When we're up and out of bed, we're in our chair and we're moving around and really using that to full advantage. So there are just some things to think about when getting a chair. Now, fortunately, you don't have to get your chair and your measurements and do all of the chair ordering and know all the options yourself. There are definitely people there that are ready to help you and ready to assist you with getting the best fit and the best adaptive devices attached to the chair that will work well for you. So, but if you know how your wheelchair should if you know how your wheelchair should fix you, then you will be able to know if your wheelchair is working properly and the best for you, and help to be able to communicate with other people. So the first thing you probably want to do is just look at how your wheelchair fits you to make sure that your body's in alignment. If you pass by a mirror, you can see if your shoulders are even, if you can look down and see if your hips are even, if your spine is as straight as it can be in the wheelchair. And so you can really just visually inspect yourself to see how things are moving. If you find that your movements are restricted, you might want to look at those kind of things. So one of the questions that we have today is determine the right dump for a manual chair. And a lot of people might not be familiar with that expression, but it's how you fit in the seat. So how far basically the bottom of the seat tilts back. So how you can sit and be positioned comfortably and correctly for your body type in that particular seat. So how can you determine that? You're really going to need probably somebody to help you work with that to see if that position is right for you. You don't want to overstretch your back too far one way or another. You don't want to be stretched back so far that you're leaning back and then you have a strain on your neck or on your back to be able to see forward. Sometimes when people are in a tilt position, in an electric chair that tilts back or in a chair that has a release manually that you can tilt back in for pressure release so that you don't have pressure straight on the bottom where you're sitting. You can be tilted back, but then your head is then pointed up towards the ceiling, which puts a strain on your neck to look to see where you're going. So the dump in the chair, you want to make sure that it is adequate so that you are seated comfortably in the chair, that you are back, that you're not going to tilt forward and roll straight out of your chair, but that you're even going to be able to sit back and be comfortable, even if you don't have sensation that your body will be in alignment. You won't be overstretching your muscles or understretching your muscles. You won't be putting undue pressure on anything. So that's a very important thing. It's certainly going to affect your balance and how you're able to move. You don't want to move your arm just a little bit and fall over in your chair. So looking at all those things are going to be very important. It is a factor that's very important to the user of the chair, and it's something that should be looked at when measuring for your chair to make sure that you are absolutely in the right position. So the question is, will too much dump create pressure sores? Well, actually, when you have when you're in one position for too long, if you have increased dump, if you have little dump, depending on how deep that seat is positioned, whenever you sit someplace for a long time, you are going to have the risk of increased pressure sores. We get way too reliant on our seating cushions and our devices to help us protect against pressure. I think we've become very, very comfortable with that. And people are seated and they think, okay, I've got my pressure dispersing cushion there, and so all of my risks for pressure sores are eliminated. But that is not, in fact, true. You still have to do your pressure releases and move your body around manually a little bit to release those pressures. So the general rule for pressure release is to do a pressure release for 15 seconds every 15 minutes. And when you're in the community of people who are using chairs with decreased sensation, if you really watch, you will not see your friends doing this. And probably people are getting by and they're doing okay. But it's when you have that problem that, you know, maybe you miss a skin check, you're not looking to see, a little red spot develops and it just continues on and keeps getting further and further and further into pressure ulcer. So pressure releases, even with your pressure dispersing cushion, is still going to be an important thing for you to do. You can do pressure releases if you have power through your arms by doing a push-up using the arms of your wheelchair to just completely remove your bottom and backside against to release pressure against those areas that are the surface up against your skin. Helps get that blood, allows that blood to circulate so that none of the small circulation is impaired in any way. Or if you're not able to do that, you can physically take your body and put your arm, drape your arm over the side of a wheelchair, and then move the trunk of your body so that you're sitting at an angle just for a few minutes so that you're kind of hanging over the side of the wheelchair, which if you don't, you can't see me, so you can't see, but I'm actually doing it as I describe it. And as you put the pressure, release the pressure, if you're leaning over the right side of the arm of your chair, it will reduce the pressure on your left side of your buttocks. You do that for 15 seconds and then go to the other side, put your left side, your left arm over the side of the chair, and you can release the pressure on your other side. Now, how do you integrate this? And every 15 minutes I have to do that. That's a little overwhelming to think about. So don't think about it in that way. Some people will actually get a watch with a timer that will go off every 15 minutes so that they do that. That works for them. That's great if that's what works for you. I myself find that it's much easier to get people actively doing these things if they have some kind of I'll say like a little game that you're playing. So when you're at home and you're watching TV in the evening time, commercials come on every 5 minutes, maybe every other commercial you do this, and it just becomes an automatic little thing. It doesn't have to be made into this very rigid, timely schedule, but it has to be very frequently done. If you have small children and you're at home, maybe every time they say mommy, 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 or daddy, 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 you can do a pressure release. Or if you're at work, if you decide you want to do a pressure release as soon as a meeting starts, and then if there's a person, make it into a little game for yourself. If there's a person who is constantly talking, maybe every time that they interrupt the meeting, or every time the phone rings, you do one of these things, or when you hang up the phone, it just becomes an automatic thing. So just try to think of a little game that you can play to kind of integrate that into your life, so that it doesn't. If I sit down and I think, okay, now every 15 minutes I have to stop and do this activity, it becomes disruptive in my life. But if I'm typing and every time I get to the end of a page of typing something, I do a pressure release, then that makes more sense, and it just becomes kind of an automatic sort of thing. So it's really those functional ways of trying to think of some little ditty that you can do to incorporate that into your life. If you don't want to count for 15 seconds in nursing, we have these little games that we play. For instance, in hand washing, this is an excellent thing to get involved with. How do you know when your hands are clean? Well, when we teach brand new novice nurses to wash their hands, we teach them how to soap and how to scrub all the sides of their hands. But we also teach them little games to play. For instance, sing happy birthday while you're sudsing your hands. That gives you the length of time that you need to be sudsing your hands, but also relieving pressure. If you recite your ABCs while you do that, or if you have a poem that you like, you might want to cite that poem. Some people might say a little prayer if they have a particularly spiritual bent, so that it doesn't become such an onerous task. I think that in spinal cord injury and in other problems, catastrophic injuries, there's so many things to do and so many things to remember. It just becomes such an onerous type of task. So if you incorporate it into your life in some particular way, that will be helpful. So the question has been presented, how often should I have my wheelchair checked? Well, you can check yourself in your wheelchair just secondarily when you're looking in the mirror. If you find that your condition has changed in any way, be sure and have your wheelchair checked the next time you're at the therapist. They can do a real quick eyeball check, discuss problems with your mobility, that would include getting around in your chair, and then you can incorporate those things into your treatment plan that need to be done. This week there's a new blog that's out about aging, and oh my goodness, the list of things that happen to us when we age, whether we have a spinal cord injury or whether we do not, is just unbelievable. As they say, getting older is not for the young. You have to be hardy to age, and there are things that you need to do with spinal cord injury. So as you age, your body changes. So if you have increased spasticity, if you've developed and cultivated a new movement, perhaps you had some ability to move a finger and you've cultivated that into capturing that movement to be able to use a joystick or something. All of those are times to have your wheelchair checked. Anytime you've gained weight or lost weight, it's time to have your wheelchair checked. Now, most insurance companies, or if you have Medicaid, usually the standard, and this is not every single policy. You always have to double check your own policy. But usually the standard is every 2 weeks a year can be used for mobility training. Now most people will interpret that, oh, well, I'm not ambulating, so I'm not walking, so I guess I don't use that benefit on my insurance or by my payer. But actually mobility training can be used for looking for advanced treatments. It can be used for having your wheelchair checked. So using those 2 weeks to how you can improve any kind of mobility. If you use a chair, if you use other assistive devices, you can use those 2 weeks every year for an upgrade and looking at how things can be worked to improve your skills. If you're seeing the physical therapist for something else entirely, but you say, I'm having a problem with my chair, they certainly, I think, would be amenable to being able to do that. So what is the weight increase to have my wheelchair checked? Well, actually, that's going to be rather individual for everyone. At 10 pounds, you need to have your wheelchair checked. If you gain 10 pounds, if you lose 10 pounds, that's kind of just a good idea to think, that's a pretty significant weight loss or gain. So you might want to have your wheelchair checked. But when you have your wheelchair checked, you also want to have your seating checked. Because if you have your seating well defined for 150 pounds, but now you weigh 160 or 170, that seating system might not be as effective for you. It may need, if it's an air-driven system, it may need more or less air in the system. So actually a little bit of weight change can make a huge difference. And it's, some people are only going to gain a couple of pounds, and suddenly, for some ladies, it's going to go right to the hips, and then the wheelchair is not going to be wide enough, and you're going to be rubbing up against the side of the chair. So look where your weight is collected, and look at the number of pounds that you've gained. If you've gained 10, you want to think about it. If you've gained 20 pounds, you certainly want to have your seating system reevaluated. Also look at how your legs, if you have gained weight but it hasn't been through metabolism, perhaps you've gained weight because you're carrying extra fluid around for some particular reason. So be sure and check your body to see if your ankles are swelling. Perhaps you want to go back to putting on your TED hose, those beautiful white stockings to keep or elevate your feet to keep that fluid from collecting in your feet. So be sure and check out why you think it is that you might be collecting that. Okay, so there is another question about seat mapping and what should I expect from it. Mapping has become extremely popular these days, and it really is quite a wonderful thing. Now, if you're not familiar with this, you might be surprised because you've seen it, but you might not know that you've seen it, and it's on TV all the time for the general public. And where you see it is on commercials for inserts in your shoes, the gel inserts, and there's very different kinds available to anyone in the public, put out by popular brand organizations. And so you can go to the store and you can stand on, they'll show it on the commercial, you can stand on like what looks like a scale, but the picture that you see is not the number of pounds that you have, but it will be a picture of the bottom of the surface of your feet in a graphic form, and it'll show where the weight of your body is affected on your feet. Now for most people, that's going to be right on the bottom of the heel because most of the body weight is going to collect there. So a red spot will appear on the heel, and then probably on the ball of the foot where the counterbalance is, there's going to be a red spot. So these things are going to be appearing. So in mapping, what happens is that there's a whole mat that you can lay on, or there's a mat that you can sit in, and the same graphic representation will appear. So when you sit on one of these pressure mapping devices, they'll show you where your pressure collects. Now when you're sitting, the pressure collecting is always going to be on those ischial bones, which are parts of the pelvis bone that are little sharp bones that rather hang down off the bottom of the pelvis. When you're sitting, those bones are right underneath your fat pad on your bottom, and they're going right up against the chair. And there's just that muscle of the gluteal muscle of your bottom, and then the fat pad that you have. Fat does not disperse pressure. Fat in your body is like a pillow. When you sit on a pillow, it doesn't cushion anything. It just collapses and adds more pressure. That's why you need to get a pressure dispersion cushion or some type of pressure dispersion that you sit on. It sometimes comes in gel form. It might be certain foams, not just any foam, but pressure dispersing foam, or it might be an air cushion. So with these, that's mostly where your pressure is going to be when you're sitting underneath your bottom. Now, when we talk about that dump in the chair and how far you tilt back, you might have more pressure on your thighs, or it could change. And that's why it's important to have the pressure mapping. If you look at a pressure map on your back, you're going to show pressure on your spine and on your shoulders. So because we kind of know where these pressure areas are, you don't necessarily need to have a pressure mapping, but it is a wonderful thing to see because you can see where your pressure spots are, and then when your pressure seating equipment is put there, you can see how that pressure has been reduced and removed and spread out so that not all the pressure is on where those bones are up next to the skin. So very good as far as seeing how your equipment is working. I love the pressure mapping because it is crystal clear where the problem areas are and then if the problem areas have been corrected. Is it something that you absolutely must demand for your care? Well, probably not because we really sort of already know that information. However, it is very nice to have a check of your seating system to see if that pressure has been removed. So we have another question here about let's see, a person who has an L5 injury. This is a wonderful question. So a lower level injury, L5 is in the lumbar area, so right at the bottom of the spine. And I would, kind of right in that small of the back, just below the small of the back. So right about where the actual spinal cord is starting to break off into the cauda equina. So just a little bit above that, right around there. So the question is, what's the research for walking in this area? And there's a lot of research that's going on right now. The big research, there is a question. I'm going to delay this response just for a moment and answer this question. And Julie, if you could tell me, I see that the hand is raised, but I don't see where I find out what I do.
Dan has his hand raised. And Dan, if you go ahead and you can start talking. If not, you're going to have to type in the chat box. Dan, are you available? I'll try to get a hold of Dan while you go on.
Okay, while we're working that out, I'll go ahead and talk about this, the research that's going on. Most everyone right now is all abuzz about the research that Dr. Susan Harkema is doing and the Christopher and Dana Reeve Paralysis Foundation is sponsoring this research where they're putting stimulators directly into the spine to see what connections. And they've done, I want to say 5 individuals, if I'm remembering correctly, who have had rather phenomenal results from having this implant put in. But this is also in addition to extensive therapy that's been going on. And so people are really very excited about this right now. It's a small number of people that have had results because only a small number have been studied. But there's a sponsored study that's now going on with a larger number. So we're quite optimistic about this, I think, in the Rehab Research Committee. I also want to mention that there are several other types of studies that are going on out in the world. There's still some stem cell studies and different studies looking at the scar that forms inside the spinal cord itself. So as of right now, this is a very exciting time to be involved in research in the neurological system, especially in spinal cord injury. However, I realize that when you're the person waiting for those results, it's never soon enough. Research takes such an awful long time, and it has to be replicated and validated, because what seems sometimes in first results seems like, oh, well, this is clearly the answer. Sometimes when more studies are done, there's complications that were not foreseen that arise. Now, I'm not saying that any of this is going to happen. I, for one, am very excited about the study that's being done with the spinal stimulators. But there's a lot of studies that are going on. So if anybody has a spinal cord injury, this certainly is a time that we should be aware of these things that are going on in the research. So we have another, yes?
I have Dan's question in the chat box.
Okay. There's a question about dance, and I'm going to go back to that, so don't think I've forgotten about you. A different topic here. This gentleman is talking about bone density, and so he was reading about the bone density information on the community, so that's great. So his test came back showing a low level of osteoporosis in his right hip, which he was recommended to take vitamin D supplements and Fosamax, which was unexpected. And do you have any idea about the differences in SCI, and particularly testosterone options besides the Fosamax? Well, actually, vitamin D and Fosamax is the usual treatment when you have osteoporosis in spinal cord injury. So that is not unusual. I'm guessing that the thought about using the Fosamax, because usually when we hear of osteoporosis, we think of little old ladies with the curves in their back, or they've fallen down and they fractured their wrists and they get a bone density test, and oops, they find out they have osteoporosis. However, osteoporosis is also common. It's not that unusual to find men with osteoporosis. It's even more common in the population of individuals with spinal cord injury due to the fact that most of these individuals are not standing and putting weight through the long bones of the leg. That's what really stimulates. Weight through the long bones of the legs is what really stimulates us to increase our bone density. So the vitamin D helps absorb calcium into the bones, which we need to keep those bones strong, and the Fosamax helps bring that in. Now, the question is testosterone, and does testosterone help? It certainly can help, but it's kind of through a roundabout way. It certainly does. It can help with our bone density, but there's a lot of other things that happen with increasing your testosterone. And so you want to think about it, do you want to work with increasing your bone density with the minimal amount of additional effects, or do you really want to blast your bone density with testosterone, which is going to have a lot more effects on your body than just the Fosamax? So those are the kinds of things we need to tease out for this. Now, if you're a gentleman and you want to have some of those other effects of testosterone, it might be a 2-for-1 kind of thing where you can deal with 2 different issues at one time. You do have to remember when you're taking the testosterone that you are taking a hormone, and so there are a significant number of side effects that really play into that. So that's something you'll really want to discuss with your doctor. To see about all the complications and all the risks that go with that, and it's going to be your decision to decide how you want to treat that. So that's a significant problem, but I would go to my healthcare professional. You have that question. I would certainly raise the question regarding the Fosamax and the testosterone. Weigh all the risk as far as finding out about the side effects of testosterone, how long the effects last, what will happen to your body, and then make your decision. Because once you have the information, then you can really make an educated decision. You might decide that, gee, I have these other issues and the testosterone would be of benefit to me. You will also want to ask how long the benefits of testosterone will last for you. Sometimes people start taking testosterone, they get benefits, and all of a sudden for one day the benefits stop working, but now they're taking a hormone so they can't stop taking the testosterone. So you need to weigh all of those options. I did want to go back to this question about a person who is dancing but lacks adequate trunk balance, and they made the seat angle in their chair different, and she wants to know about pressure sores when she remains seated in the chair for long hours for wheelchair dancing. Well, first of all, what a great way to get some exercise, because when you're wheelchair dancing, the benefit to that is going to be that you're probably going to be breathing deeper and getting some air into your lungs. And so you're probably going to be getting some good exercise in that way. If you've changed the angle of your seat, you will still want to make sure that you have that pressure dispersion for where you're sitting to make sure that you haven't changed the pressure. If you're dancing for long hours, that sounds really very exciting. You might want to do some pressure relief when the music changes from one number to another. That would be a good little way that you could remember. But also to make sure that you have that pressure reducing, that you haven't eliminated your pressure reduction with your seating. But you'll still need to do that pressure release at some point in time, and probably in between numbers, just a quick little a jolt this way or that way to release that pressure. Now when you're dancing, you might be doing some of the movements and you might be moving within your chair enough that you're doing pressure releases constantly. So if you are in a dance studio, or if you have a place where you can see how your body's moving where you're dancing, you might see that you are changing your pelvis, or you might see your hips being changed around in your chair, which would be good. But be sure and check your seating system to make sure that you are getting those pressure reducing exercises in. And then let's see. I'm kind of behind in my scrolling down here. Okay, so let's see. The question is, a follow-up question to that is what does it mean for people to have L5 damage? Well, you're talking about a difference between a damage exactly to the spinal cord itself versus damage to the cauda equina. So the spinal cord is really, if you think of the spinal cord, it's a bundle of nerve fibers that come from the brain and come all the way down through your spine. I think you could think of these nerve fibers basically like a ponytail. So when they're in your vertebrae, it's like a ponytail inside that bony encapsulation of your vertebrae. But these fibers trail off at different places in between the vertebrae. So you have nerves that trail off that help control arm movement. You have, in between each of those vertebrae, there's little holes in them, and some nerve fibers come off and go into your body. And so you go further down your spinal cord, there's some nerve fibers that go through and help control the trunk of your body. And then there are nerve fibers when it gets down to the end of the spinal cord. It's not really so much like a solid ponytail, but it's a series of fibers that trail off into various areas, and this is what they call the cauda equina, or the horse's tail. So that kind of gives you an image of what they're talking about. Those nerve fibers trail off down to your legs and feet. Some trail off to your bowel and bladder. Some are working within your abdomen. Some are there that are just going to help with sexual function and controlling those sensations. And so you see we have a bunch of nerves that are going around. So when you have an injury to the cauda equina, you have a different set of issues. When the nerves are in the spinal cord itself, in the bony vertebrae, they're still a part of the central nervous system. When they come out of the vertebrae or the cauda equina, those nerves are part of the peripheral nervous system. And there's quite a distinction in the way that those nerves work and what happens with those nerves. They're still controlled all by the brain, but we can do a lot more work with nerves in the peripheral nervous system than we can with nerves in the central nervous system. Those nerves are still kind of more of a mystery. We have a lot more research and a lot more evidence of things that we can do with the peripheral nervous system. So when you have that L5 injury, you're dealing more with the peripheral nervous system, in which case there are nerve transfers that can be attempted. You can work more with individual nerves. When you're in the central spinal cord, when you're in the central nervous system, you don't really know which exact nerve is going to where. So if you think about, I have a ponytail and I cut it off, it's like a spinal cord injury, but now I need to put those nerves back together. You need to match them up, so to speak. Now we're finding that that's not necessarily as true as we used to think it was. But when you're in the peripheral nervous system, you can say this particular nerve fiber controls that particular action or controls that particular sensation. So that is what the key difference is between people who have an injury in their peripheral nervous system versus in their central nervous system. So people with the nerve damage in the cauda equina oftentimes have more problems getting those electrical conductions to go through. They have more flaccid type of injury versus spastic type of injury, and it all has to do with what type of nerve is injured. But there's a lot more treatments and things you can do with the peripheral nerves than with the spinal cord, with the central nerves. So you really want to be sure and check with your healthcare provider for different treatments, because the treatments are going to be different depending on how that is. It's actually kind of if you have to say which is the better injury, which is a horrible thing to say, none of the injuries are good, but it probably is more fortunate for you to have a damage in the lower nerves than in the higher nerves. So the next question is, what age do you recommend getting a bone density test? Well, now usually when women hit, if we're going in traditional kinds of things, usually when women hit about age 50, they start going for bone density tests. There's a lot of flexibility in that. If people don't have any issues, they're physically fit, they get a lot of exercise, the chance of having low bone density is lower, and so they might put that off. Now, at what age should you get a bone density test? You should get one when you have a spinal cord injury. And the reason for that is that will set your baseline. From there, then you can look and see, usually bone density tests are done yearly after a spinal cord injury, so that you can see from your baseline how your bone density has changed. So if you start out with a lower bone density, you're going to have a lot quicker losing more calcium in your bones than if you start out with a really strong bone density. So usually people have one when they have a spinal cord injury, not the minute they have it, after they've gone through the first rehabilitation process, but at about that time when you're coming out from the rehab hospital, when you're starting to get settled in your home life, that's about time to start to get your first bone density so that you have a good baseline, so you know where you're starting and how you need to progress from there. And then after that, it's really once a year to see how your bones are doing. They only do the tests on 3 areas in your body, and then they extrapolate out from that what your density is in different parts of your body. So it's a very simple test. You just don't want to wear any metal when you go to do it. You lay on a table. There's like a wand that automatically goes around your body. It never touches you. It's not even radiation like a chest X-ray. It's a different form of scanning. So there's no IV, there's no dye that is injected. Nobody touches your body really at all except to help you move on to the table. And then you just lay there. So it's totally painless. It's about the easiest test you can have when you go in to the doctor. Okay, another question, Botox for the bladder. This person's been taking Ditropan for 33 years and emptied their bladder with a catheter. And so they're talking about doing some Botox in the bladder. And basically, Botox is used for spasticity. Now, we all know about Botox that's injected into people's faces for cosmetic reasons. It takes away the wrinkles. But the way it works is that it is injected into muscles. And then the muscles, Botox is botulinum toxin. So it is a paralytic agent that just works in very, very tiny spots in muscles, just enough so that that spasticity is reduced and you don't have that constant contraction of that muscle. It's very, very good for bladder spasms to help slow the tone of the muscle. Remember, if you're having a bladder spasm, that muscle's going to be involuntarily contracting and probably holding. It can be repeated. So when that bladder contracts, what happens is that urine is pushed someplace. Hopefully it's pushed outside the bladder through the urethra, and you become incontinent. Well, you don't want to be incontinent, so you don't want that to happen. But if it does go out and you become incontinent, that is better than the other option is up through the ureters back into the kidneys. So if there's only 3, the bladder has only 3 openings in it, 2 from the ureters, which are the tubes that go from the kidney to the bladder, and 1 from the bladder out of the body where urine's expelled. So if the bladder spasms, the urine's either going to go back up into the kidneys, which the kidneys do not expand or contract. So if urine goes up there, then you have kidney damage. You don't want that. Or the urine's going to be expelled out through the urethra, and you'll have wetness. So the Botox in the bladder is given, it's injected directly into the bladder. They put a tube in through the urethra, and they inject the Botox into spots placed around in the bladder to help calm that spasticity in the bladder. once that's calmed and the bladder's relaxed, then you don't have that contraction and you don't have the chance of the urine going back up into those kidneys. And then also it can help from squirting out, so you reduce incontinency and thereby reduce your chance of pressure sores from being wet. So it's very, very helpful. The nice thing about Botox is that it only lasts for 6 months. I guess that's a good thing and a bad thing. So they will inject the bladder, and the doctor has experience in doing this. They know how much to inject. They know where to inject, and so they do that. Now, after a few months, about 6 months, that will wear off, and you have to have it done again. And that's okay. You can have it done again without problems. The good news about that is if for some reason it gets over-injected, the usual treatment maybe is too much for your spasticity or something, you know that whatever problem you have will resolve. If you have a problem from the Botox, it will resolve in 6 months. So, and then you just have it done again. Botox has just been approved. It's been used for spasticity in arms and legs, but it was never approved for that. You'd have to get a special exemption to have that done. But a lot of people have Botox injected into their legs for spasticity, into their arms. People with migraine headaches, if that is what their problem is, they inject it into the back of the scalp, not into the brain, because you've got your skull there to protect you from that. But they'll inject it into the back of the scalp, and that seems to resolve migraine headaches. Very, very successful treatment. So, you know, if you want to talk to your doctor and think about having the Botox, it might help you reduce some of your ditropan, or after 33 years of taking ditropan, you perhaps have become tolerant to it. Or, as you'll see in this week's blog, even if we have treatment for 33 years and it's all going just fine, as we age, our body's changing unbeknownst to us. We don't get to see those things. It changes, and maybe this might be just the next step in a treatment that might be, you know, to help you continue to be able to empty your bladder with a catheter. So you know, your doctor has suggested it. Be sure and talk to your doctor about experience with doing it. What have other people had success? What the complications are? All these, you know, these questions, so that you can become better educated, so that you'll know about that. But it is a very highly successful treatment. Let's see. Talking about urine, if you take more intake, then urine leaks. Yes, if you take in more fluid, you might have some leakage. You might need to catheterize on a different schedule. It becomes difficult for a woman to catheterize herself. Yes, there's a lot of different positions that you can use for catheterization that might be helpful to you. If you can transfer onto a toilet, there are some new catheters that are just a few inches long that you don't even, you know, there's really, besides cleaning yourself before catheterizing, and then you can catheterize directly into the toilet. Some people will tilt their body so that they have, for women, so that they have that position that they can get to. Let's see, some people will remove the arm of their chair and be able to drape one leg over so they have access to getting it. Again, it's finding what works for you. You can work with your physical therapist. You can work with an occupational therapist for different positioning. For women, it is always a challenge if you have difficulty moving about, but trying to find a position for yourself is something that is something that you can try to see if you can accomplish that goal. Let's see. Here's a question about someone writes in about being having a C4-5 injury. Do you think that they'll ever be able to transfer themselves from bed to chair? Well, you know, actually, I think it is a possibility. Now, I'm sure that your question, you're thinking in your mind, will they be able to do this independently by themselves? And I'm sure you're thinking about them physically moving themselves. And is it a possibility? Well, I think with all the options and treatments that are out there right now, I think that, you know, we can't say no to anything. However, in looking at that level of injury and some of the adaptive equipment, do you think that this person would be able to transfer themselves? It's a possibility. Leaving yourself open to adaptive equipment, it might be possible. C4 or 5, if they have some shoulder control and can put their arms through some loops that are stiff, you know, so that your arms don't just flop right out. But might they be able to independently use some kind of a lift or some kind of device? It's a possibility. The important thing to remember about spinal cord injury is no matter what your injury is, your body is always trying to heal itself. If you think about you get a cut on your hand, your skin will heal itself. And that happens pretty quickly. You get a little cut on your finger, and in a few days, in a week, you don't even see it anymore because your body has healed it. Your nervous system is always trying to repair itself too. It just happens in a much, much slower fashion. And if you keep up with your exercises, keep up with your therapy. Now I know that oftentimes we don't have a payer that's going to pay us to go to a therapist, but if we keep up our exercises at home and we do our exercises, is it a possibility? With all this research that we have been discussing, you know, anything is certainly in the realm of possibility. As your body slowly tries to heal itself, you're going to get stronger and stronger. I see a lot of people who unfortunately are told, well, you have a spinal cord injury, so, you know, don't even try anymore. And certainly I'm so old, that's the way I was taught in nursing school. That's what we were taught. And a lot of people, I think, still carry that message with them. It's an unfortunate message. I think if you keep trying and keep working towards it, you'll find yourself getting stronger and stronger and stronger. So there's all kinds of possibilities out there. That's a possibility that could happen. So let's see. Catheters being not the special catheters for females not being available in India. Yes, that's probably true. Probably not everything is available at your vendor in India. However, I bet you can get almost anything off the Internet. And so if you look at those and go to different catheter companies, you're probably going to find you'll be able to purchase those from another country. Now, you know, we're talking about shipping to other countries. We're talking about costs. You know, all of those are barriers, but we can think about, you know, how we can get past those things and see what kinds of things you can do to, you know, circumvent the financial issue. See if you can get some funding sources, see if you can get some help. I'm not quite sure what the healthcare system is like in India, but if you have any resources you might be able to purchase from maybe not the United States, but Great Britain, who really has a lot of research and a lot of opportunities for you to purchase things. There's a question about some other things for females. Velcro pant seams, certainly that helps. A lot of times women will go, as they say here, go commando without underwear, so you don't have to manipulate around underwear. Men sometimes even go commando without underwear so that they don't have that extra layer of clothes that they have to kind of navigate through, especially if you have limited hand function. If you have a 14 French catheter, you can cut and shorten it. You sure can. 7 inches is typically what is used. You don't want to get it too short. You want to be sure and have enough a catheter left over to be able to remove that catheter. But in most products, a short female catheter is 7 inches long. So that might be something you might want to try. Some people prefer long catheters. You can use long catheters. Sometimes if you have a longer catheter, and there are some extremely long catheters that you can buy, so you can sit in a chair and still have enough catheter to shoot over to a toilet or some kind of receptacle. So there's all kinds of options. If you look at some of the big catheter companies, or some of the medical supply catheters, they will have every kind of catheter you can possibly imagine. There are catheters that come with it inside their own drainage bag. There are catheters that are pre-lubricated. There are catheters that have antibiotic already on the tip of the catheter, or they have other kinds of bacteria reducing catheter tips. So there's just all kinds of sources of catheters and things that you might want to try. Now I will say, don't jump into a catheter with antibiotic tips, or I do want to make a mention about people who use antibiotic soap for cleaning before catheterization. Don't jump right into those. If you're just using plain soap and water and you're doing fine, just continue to do that. Right now in the world, we have this problem with bacteria, and that bacteria are becoming resistant. So there's a lot of wipes that you can buy for your kitchen counters that are all antibacterial. We all need a little certain amount of bacteria in our lives. Now, not enough to become sick, but a little bit of bacteria in our lives so we can build up immunities to these. If we use too much antibiotics, then we have that problem of building up those immunities. So sounds like a blog for in the future. So stay tuned, and we'll keep talking about these things. So we'll just keep, please be sure, and if you have a question that you'd like answered, please just feel free to write into the blog. I get a lot of questions, and I'm always happy to answer them. It gives me ideas for new blogs, and it helps me see what people are really interested in. So we'll continue the conversation, and I hope very much to see you next month. And keep reading the blog, and we'll see what we come up with.
Thank you, Nurse Linda. I want to thank you. We're at the top of the hour, and Nurse Linda just has to go. So I want to thank everybody for joining us today. And I'm hoping next month, the end of the month, when she does her next web chat, that we can get more people talking. So she doesn't have to talk so much. She's going to lose her voice. So I'd like to thank everybody for joining us today on the call. And you'll be look on christopherreeve.org/nurse for the link to the archived video of this web chat so you can view it later. And look for the link to sign up for May's web chat with Nurse Linda. So thank you everybody for coming, and wish everybody a good day.
Thank you. Bye.